for about 10 or 15 years. And that is the patient's expectations of what these medicines are going to do and physician compliance with requests. I saw an advertisement in a magazine for this medicine, and I want you to prescribe it for me because I have this condition and you need to fix it.
And I read about it on the web.
I saw it on the internet. Perhaps one of the most dangerous places for electrons to go. Does this lead to a push for the drug companies to get new therapeutics out because there's a marketplace out there and the public will demand this of their doctors and go that way? So it's commercial, and all the good and bad things that go with it. The parts about this that drive me nuts is a little bit is we start blurring the lines a little bit. They advertise to the public, and they're all over the place. I mean, you'll see them on TV for sure. Advair and Boniva. You know, Forrest Gump's mother was advertising Boniva. Okay. Avodar. I haven't seen that guy anymore. The guy whose prostate's the size of the planet Mars. He has trouble going to the bathroom for the rest of his life, and he has to take a break and take that pill. Or Cialis, another that one's out there all the time. And then there are these. If you have trouble paying for your drugs, contact Pfizer. We can help you. The way we can help you is we can give you a coupon for a month's worth of this drug. After that, we've got you. You're taking this medicine, you're getting the effect of the drug, figure out a way to pay for it. So some of these introductory offers are ways to get patients to start taking a medication that they may need to take on a chronic basis. I'm not sure that you're going to be getting prescription coupons to get amoxicillin for your child's otitis media, because that's going to be a one-time, I'm going to treat you for 10 days and be done, rather than a medication that's going to be of a chronic use for an ongoing condition. So we see these things all the time. Yeah?
Is that kind of making almost like a placebo type effect with these drugs where people think they have symptoms based off the advertisement, where like in the placebo they think they're getting better and almost kind of
what it's doing is symptoms? They're not advertising a drug that isn't for the purpose that they're advertising. Okay? When you look at all these immune modulators that they advertise now, Enbrel and Humira and all this other stuff for my psoriasis got better, my rheumatoid arthritis got better, my lupus got better, and they always show these people who begin who like can't do anything, and by the time they're done, they're jumping rope, playing varsity baseball, they're Olympic contenders, and all because they took this immune modulating drug. And then, while they're out romping in the wildflowers, with pastel colors and hair blowing and looking like $1 million, the narrator is saying, you should be aware that you have to have your liver enzymes checked every week, that this can cause severe immune things. It can uncover tuberculosis, may cause lymphomas, and they list all this horrific crap, which is juxtaposed against nirvana, and then you're trying to figure out, yeah, but that's not going to happen to me. Obviously, if it happened to everyone, they couldn't have that drug on the market because it can't. You can't release a medication like that. But they're disclosing potential badness. And this isn't badness like, your hair may thin for a week. This is badness like, you're going to get a sarcoma and die from this. And so, that's just an important thing. I had a guy come to the ER a month ago asking me to prescribe Enbrel for him because he has psoriasis. And I said, where did you hear about this? Well, I saw it on television. And the psoriasis went away. And this guy had some patches of psoriasis, and these immune modulators work for people who have disabling recurrent infection, psoriasis, bad things that you want to monkey with their body defenses to reduce the inflammation of the psoriasis. But I said, this is given by infusion, this is not something we do in the ER. You need a consultation with a dermatologist to walk you through other ways to control this, because you really don't want to be on this drug with the extent of disease that you have. But this is what it comes to when people start seeing this. They start doing this. They start asking for prescriptions, and I don't think that that's the greatest way necessarily for us to be practicing medication delivery. Yes, and then yes.
Is there a set like percentage as far as side effects go, or is it just kind of cost versus benefit? Like if only 5% of people get suicidal tendencies with taking a drug and kill themselves, like is that an acceptable thing, or is it just like if one person kills themselves?
That's a really good question.
Not that
I don't
big.
know that there are absolute thresholds. Somebody may kill themselves. They worry about, for example, when you start administering an antidepressant to patients, that in the first several weeks of taking the medication, patients may be at a high risk for suicide, especially adolescents. Does that mean that you don't use that drug because it has a very good long-term profile of preventing, disabling depression and gets people back in the game? No, but you have to be careful that there's a watch period that everybody needs to know that if this person starts behaving differently or gets more activated as part of the resolution of their depression, that everybody has to be in tune to the fact that there's a known risk period for that to happen. But it doesn't mean that you sort of discard the entire classification of medications because of the known risk. Now, if you find out that almost everybody who takes this particular drug for their diabetes is going to get an advancement of their cardiac disease, we got other drugs that you could be taking. And so what the FDA will do is if it's a really dangerous drug, they'll pull it. The other thing they'll do is they will issue what's called a black box warning. So in the prescribing information for physicians, there's going to be a black box with a warning that says, this drug is known to cause an increase in. If you elect to prescribe, it's still out there because it does good things, but if you elect to prescribe it, you need to understand, and so does your patient, that these are the things that that you can encounter. So then it's a risk-benefit profile. Do we want to incur this risk to take care of this? Have we exhausted other forms of treatment that don't have a black box warning, that may have been around 10 years longer with hundreds of thousands of more reports of what their side effects are and are not? That we'd say, let's start here. There's an old rule I learned when I was in medical school. You never want to be the first practitioner around to start using a new drug. Okay? But you don't want to be the last guy either. You want to sort of, you kind of want to ride the wave. Problem is, you can't read the wave, and you don't know what's going to happen until it happens. But it's an interesting, it's just an interesting line of caution to have, I think.
I just wondered if you had something that was revolutionary, like we found a cure for cancer, but it kills 1 in 4 people. Like, are we going to go ahead and say, look, it kills 1 in 4 people, but you have cancer, which is going to kill you anyway? You're welcome to it if you want it. It's available, but
then there has to be some sort of an informed consent to the patient. You need to understand that this is out there. It may be very effective for your condition. There are some horrible side effects. Part of that is what we owe our patients as prescribers. When somebody entrusts their care to us and we go into some huge pharmacologic compendium and say, that's the drug for you, I want to be sure that you know that that's the drug for you. People have traditionally not asked, just give me a prescription so I can get rid of this and move on. Then they go on the internet and they look up this drug and they say, well, it causes lightheadedness. I'm feeling a little lightheaded. I'm not going to take this drug. That's a bad drug for me. Well, wait a second. If I know that this drug causes lightheadedness and I prescribe it for you and say, listen, you need to be on this for 3 weeks, the first few days of this, you're likely to feel this, this, and this. You may not, but you might. Don't be afraid. You can call me and we'll talk about it some more, but I think that this is a good choice for you. We have this huge breakdown of this, because people are just machined through. And I think, we owe it to our patients to explain to them what we're doing and explain the side effects that they're going to have. So when I give somebody 12 of adenosine, for example, for their tachyarrhythmia, and they get chest discomfort and then they feel like they're going to die because their heart stopped for a moment, I need to tell them this. Look, this may make you feel tightness here for a minute. You may feel momentarily faint, the drug's going to be gone quickly. We are here right with you. Okay. Yep, there it is. I feel it. I'm done. So, how much of that is our fault versus the drug's fault or the drug maker's fault? These are tools for us, and we have to know how to use them. If I give somebody propofol, and right after Michael Jackson died, 4 years ago, and and they hear that we're using propofol. I don't want that drug. That kills people. Not necessarily. Here's what you're going to feel. Here's what's going to happen. And in 10 minutes, we're going to be done. The drug's going to be gone. But part of that's our doing. Someone else had a hand over here.
I was answering.
Okay. All right. Part of the problem is we have so many drugs that there's too many drugs and too little memory. So how do I know what I'm doing? So there's all these sources of drug information that we can get medically. We get information from the FDA. We get information from the physician's desk reference, which is a compendium of drugs that's out there. It used to come in a big nasty book. Now you can get it online. There are hospital formularies of the kinds of drugs that we carry and how we use them. And there are package inserts. And those are those things that are folded up into a little piece of paper this big that when you unroll it, it makes the Dead Sea Scrolls, look like a piece of Kleenex. Big with a print that no one can read. And that's all the information that's in there. So we have our peripheral brains. Everybody's got one by now. And you can load an application on that will have pictures of pills by color and dosing and name and stuff. That will have the name of the drug. You can look up the drug. It tells you what the generic is, how it's given, if there are any black box warnings, what it's used for, all of that kind of stuff. Some of these are free. Some of them, a lot of people download the free ones for an extra, $20 or something like that. They update them regularly. There's more detailed information in these programs. I find it incredibly useful. I used to think when I was at school that if a physician had to go look up in a book what drug this patient was taking, that the physician was ignorant. And that was then when there were not anywhere near as many drugs and spin-offs as there are now. So in order to have the data handy, and there's so many new drugs, especially for cardiovascular drugs, changes in antibiotics and anti-seizure medications, that you've got to have access to this stuff. You go to somebody's house and open the medicine chest and see 25 bottles in there, 3 of which are current and the other 22 are from God knows when. You don't know what they're taking, they can't tell you, and can I group these into categories? Oh, these are all different beta blockers. These are all antihypertensives. Patient's got cardiac disease, they've got high blood pressure, I got it. You can start putting pieces together. And some of these things will tell you if drug A interferes with drug B, which is a useful thing because you may be giving drug B, and you want to know that. So these are definitely available.
Dr. Rottman?
Yeah.
Is there an app that you would recommend that might be useful for paramedics?
A lot of people use an app called Epocrates, Epocrates. And a lot of my residents use that one a lot. There's another one called Tarascon, Tarascon, I think. The thing that I think the people like about Hippocrates is it has the visual images of what the pills look like. Some of them come with calculators and drug dosing calculators and stuff in them, which are pretty helpful. But either of those I think are very good.
Thanks.
Prescription versus over-the-counter. Prescription drugs are drugs that only medical professionals can prescribe. Medical professionals does not only mean doctors, it means nurse practitioners. It may be physician assistants working under the auspices of the physician. It may be a dentist or an oral surgeon who can prescribe opiates and antibiotics. Okay? So it could be all over the place. Over-the-counters, they're all over the place. Okay? You see them everywhere. 7-Eleven, Ralph's, CVS, liquor stores, Office Depot, all these over-the-counter pain medicines and stuff. To go from a prescription to an over-the-counter availability, it happens when the FDA judges that a drug is safe so that, and here's the key, most reasonable users won't hurt themselves by misusing it. Okay? It used to be that if you wanted ibuprofen, you had to get a prescription for Advil. That drug is now over the counter. It used to be if you wanted a phone call and you're behind, that you'd have to go like this. It used to be that if there is no phone service here except in my pants pocket for some reason, I don't know why. it used to be that if you wanted a prescription for Benadryl, it was by prescription only. Now it's over the counter in 25 milligrams high. So this leads us to things like Tylenol. Can you take too much Tylenol? Yeah, you can. It's over the counter, and it's actually always been over the counter. But it's a dangerous drug if it's misused. So it's just something to keep aware of. Yeah.
What do we fall under when we administer like morphine or anything like that?
You fall under the medical director of the agency for whom you work.
And is it technically prescription or
You're administering it as a provider. You're not prescribing it.
yeah?
Okay. So somebody is authorizing its use, and you as a certified healthcare provider can give that drug. But in order for you to stock it on your rig, somebody has to sign an authorization that's ordering that from some supplier to get it in your hand. And so that in this county, it's done by either the medical director of the county, or if you work for a municipality that has its own municipal services, it has a medical director who will cover that for you, and it's done that way. And then the ordering of that is done either by a duly certified authorized nurse from a base hospital, or under protocols by the health agency that you're working for. Okay. How do we know what to call these drugs? They're named by different things. There's a chemical name. I wouldn't even begin to pronounce this. There aren't enough hours in the day. There are generic names. This is the generic name for this chemical name. Okay, Paladifil. Then there's a trade name. Okay, it's the brand name. So instead of going to having dinner with one of your buddies and saying, well, I just got this prescription for Paladifil, no one's going to call it that. They're going to call it the trade name instead, the brand name. Okay, anybody know what that is?
Cialis?
Yeah. Okay. We won't ask Kyle.
Not that I'm on it. I just watch TV.
And then there's the official name by the Food and Drug
Not that old.
Administration that's listed in the United States Registry of Drugs, the U.S. Pharmacokinetics, and the official name is Paladifil. But they come up with names that are going to be catchy and neat, and that are going to make people remember them. So no one says I take diazepam; they say I take Valium. So right here's the brand name. Right, that's part of the problem. So Cialis, Cialis actually is an enzyme that inhibits the breakdown of a certain product that we make. Remember that all that ATP stuff? It will come back and bite you again. Okay? If adenosine isn't a triphosphate, if it only has one, it's called adenosine monophosphate. Okay? And when it's acted on by an enzyme called adenyl cyclase, it takes it in its straight form and it cyclates it. It makes it cyclical AMP. Okay? So it turns out that cyclical AMP is the business end that causes bronchodilation. Okay? So when we use an albuterol inhaler, we're actually making cyclical AMP in the bronchial smooth muscles. We're stimulating a sequence of events that make cyclical AMP. And when we break that down, then the bronchi go back into their normal tone. There's a cyclical form of another amino acid called guanosine monophosphate, cyclical GMP. And that actually causes vascular smooth muscle relaxation. So when you take Cialis or Viagra or any of those, what you're doing is you're inhibiting the enzyme that breaks down cyclical MP, okay, guanosine monophosphate. And that means that there's more of it around, which means that vascular smooth muscle stays dilated more. This is important in reproductive health because the thing that causes an erection is vascular dilation. And so when people take Cialis or any of those drugs, they're acting biochemically analogously to the way we act to cause bronchodilation. We're causing vascular smooth muscle dilation. And so you wind up with more vascular flow. This is why we ask questions about people if they're taking a drug like that before we give them nitroglycerin in the field. because nitroglycerin is also a vascular smooth muscle vasodilator. And so if they're taking Cialis, which can last for hours and hours and hours, then, and then you give them nitroglycerin, you're compounding one smooth muscle dilator with another, and you can drop their blood pressure. Okay. There's special considerations for medicines that we also have to be aware of, and that's dealing with pregnant patients. There's a risk-benefit to every drug you give, and there's a special risk-benefit to treating a mother who's pregnant, okay? Because there's a risk to the fetus potentially, and we catalog these risks to the fetus as being category A, B, C, D, and X. A is there have been well-controlled human studies that have looked at the effect of this drug on a fetus and have found that it is completely, absolutely, totally safe. Okay, there's no evidence of risk. Category B is we've looked at animal reproduction studies and have failed to demonstrate a risk to the fetus in an animal. These are done in mammals. And there's no adequate or well-controlled studies in pregnant women, but there's been so many studies of similar species that we think we're probably okay. Or we have had some well-controlled studies in women, and they have failed to demonstrate a risk. So category A or B are, we feel that we're in the safe zone in terms of treating a mom for a condition with a drug that we know is going to go through the placenta and expose the fetus to the drug. Category C is that we've got animal studies that have shown an adverse effect on the fetus, and there aren't any good or well-controlled studies in humans. Okay? But the potential benefits may warrant the use of the drug in pregnant women despite these potential risks. For example, if I have to treat somebody with an anticonvulsant, I can't leave somebody have epilepsy and be seizing all the time. It may cause skeletal abnormalities in the animals. I don't have any data in people, but because I've got trouble with animals, but I don't have data in people, but I can't leave people like this seizing, it's a category C drug. Okay. Category D drugs, there is positive evidence of human fetal risk based on adverse data, reaction data from investigational or marketing studies, and you cannot use it, okay? There may still be some potential benefits that would warrant the use of these drugs despite those risks, but you would have to really convince yourself that this mom is so ill and needs this drug, I have no choice. It's kind of like doing a CAT scan for a pregnant woman who's a multiply traumatized patient. I don't want to expose the abdomen to radiation, but the symptoms of this seatbelt injury across here are so significant that if I don't take care of this mother and she's exsanguinating, I have no baby to take care of. So we need to cross that threshold and consider the risk of irradiation and exposure at this level because your options are limited. And then category X there are fetal abnormalities, there's positive evidence of human abnormalities, and you know you're going to have a problem if you take that drug, as a pregnant woman, and we don't use those. And I'll give you a classic story of this. Did you ever hear of the drug thalidomide? Thalidomide was an anti-vomiting drug, okay? It was used for morning sickness in the 50s throughout Europe. There were more than 10,000 kids in 46 countries who were born with deformities like this. No limbs. There were some kids who were born with very bad development in their legs. These are now people born in the 50s. These people are 60 years old. Okay. Frances Kelly was a woman physician, PhD, who was a reviewer for the U.S. Food and Drug Administration at the time that this drug was being widely used in the 50s, before we saw all this. And she looked at this and she said, I'm not going to authorize thalidomide for use in the United States because I'm concerned about its safety. There was an occasional sporadic link between a mom who took thalidomide for morning sickness and a child that was born with a limb deformity. And she looked at that and said, we don't have enough data yet to know whether this is thalidomide based or not. We don't have this drug available in the US, we are not going to license it. She's like an unsung hero because she prevented this from going on in our country. She was the lone voice. Okay. So you see that these approval processes have, there's some rationale behind them. Sure, some of the appointees may be politically appointed to be on the FDA evaluation committee, but by and large, you're supposed to be doing the right thing for the patient. Okay. Yeah.
Would epi be a B, class B?
It's a known I'd have to look it up, actually. But if we're starting to think about what we would use that drug for, if I've got somebody who's got a severe allergic reaction, terrible asthma, you know, or profound hypotension, none of this is good for the fetus. If I don't correct what's going on with the mom, the fetus is struggling. And so it may be, I don't know what it's, I can look it up, but whatever its category is, you have to weigh out what it is that you're trying to, you know, what you're trying to accomplish. You know, it's the same issue of, gee, this drug causes cardiac irritability, but the patient's really wheezing a lot. What should I do? Well, part of your cardiac irritability is that you're hypoxic. If I don't fix this, I can't leave you smothered because this drug may do something else. I need to fix my root cause. And I think that that's where we go with these decisions.
Category C.
It's C? Okay. Then we have pediatric considerations. You know, we give all these drugs and we give drugs to kids and they have less developed liver function, and the liver is the primary detoxifier of our drug. And so, you know, they are variably metabolizing things. You can have newborn babies that are born and then 2 days after they're born they turn yellow. What's that all about? Their liver hasn't quite matured yet. Okay, and so they develop neonatal jaundice. And then as the liver catches up with the demands that are placed on it by red cells that are being broken down normally, then the jaundice goes away. So it shows you how the immaturity of a pediatric organ may affect the metabolism of the drugs that we may need to give them. A lot of these medicines stick around longer than they do for adults. Of course, then there's midazolam, Versed, short-acting benzo. We use that drug a lot. We use it for seizures, we use it for sedation. Sometimes children metabolize this really quickly and you're giving dosings to them that, you know, that would make you in a coma. And sometimes kids get pretty agitated by it. So it's hard to know. They may also have erratic GI absorption just because of the maturity of their gut, what their gut is learning to digest in terms of solid foods versus just formula. And then we have to dose them by weight. We rarely dose humans by weight, adult humans. We rarely dose adults by weight. You know, if you're going to take a drug, you're going to take 250 milligrams a day, whether you're this big or whether you're this big. But if you're a child, you're going to take 40 milligrams per kilogram. You know, so there's a lot of thinking going on now about how we dose drugs in adults, because different adults are different sizes, they have different percentages of body fat. Some of the drugs are fat stored, they have different renal function, they have different hepatic function, and so some of what we do, one size may not fit everybody in terms of an adult, it may be too much. If you take somebody who used to be 5'6", who's now 5 feet tall, who weighs 87 pounds and is 90 years old, and give them the same dose of an antihypertensive that you're going to give a 180-pound 40-year-old guy, you can expect different effects on their constitution. Okay, so a lot of this is we may start small and go bigger when you're dosing like that. Especially in our case, because if we're giving drugs parenterally, which is pretty much all we do, you can always give more. These drugs are supposed to work relatively quickly in the field. And so if I give some, and I'm not there, I have to give enough, but I don't want to give too much. And so there's this dosing range that happens, and some of it's judgmental. I'm thinking specifically about opiates. And if I'm going to give somebody some IV morphine, 2 milligrams may be way too much for somebody, and it may not even touch somebody else. So you can always give more. Then there are geriatric considerations. Yes. Benjamin, Brad, Pitt, Button. Here's the deal. People over 65 only make up about 15% of our population, but they use a third of all the prescription drugs that are out there. Okay. They range between 2 to 6 prescription drugs a day, and another up to 3 over-the-counter preparations a day. So I've got people who are getting older, some much older, who are taking the bulk of my prescription and over-the-counter medications, and they may be cognitively confused. They may have confounding drugs that are interacting with each other. They went to see this guy who put him on this drug, then they had an earache and he put him on that drug, and then they went to see this person for high blood pressure and they went on this drug. And suddenly they have 8 different classifications of drugs, 2 of which shouldn't be in the same room at the same time, let alone in the same person. And who's minding the shop? Okay, so this pharmacologic reconciliation is also very important. Another concern about medications rests with unsubstantiated fears of a good medicine by the public. Okay, anybody ever hear of Andrew Wakefield? Andrew Wakefield was a British gastroenterologist, a research gastroenterologist, who published a paper in The Lancet in 1998. The Lancet is the British equivalent of the New England Journal of Medicine. It is their premier internal medicine journal. And he hypothesized that autistic enterocolitis, okay, the bowel disturbances that are commonly associated with autism, was a kind of an emerging form of an inflammatory bowel disease that follows from exposure to the measles, mumps, and rubella vaccine. Okay, he hypothesized that this happens because these drugs are given to children during a period when their immune systems are rapidly developing, and that this leads to some sort of a leaky colon that allows viral toxins to gain entry and get absorbed and end up in the brain. And so when he published this paper in 1998 of 12 kids with intestinal disorders who were autistic, who had received measles, mumps, and rubella vaccine, people stopped vaccinating their kids because vaccine causes autism. And that was the causal construction that developed out of this paper. But researchers had identified a high incidence of bowel symptoms in autistic kids well before this measles, mumps, and rubella vaccine was even licensed. Nonetheless, they stopped vaccinating their kids. Okay, and this went on for a long time. If you go on the internet and look up autism and vaccination, there will be many, many websites. There are organizations that are formed, lobbying organizations, trying to get the Centers for Disease Control to do something about measles, mumps, and rubella vaccine because it causes, in their eyes, autism. The diagnosis of autism spectrum has gotten much more refined. It's more inclusive. We are seeing more people who carry the diagnosis of autism spectrum. And so, and everybody's been getting vaccinated for all these years against measles, mumps, rubella, and everything else. So the question is, are we capturing a broader segment of the population that has this condition? And by the way, everybody's been vaccinated. So do I link the increased number to my diagnostic capacity, or do I link it to the fact that we have a vaccine? Knowing that we had autism well before we ever had the vaccine. The other problem was there have been many, many scientifically done studies in different countries looking at causal relationships between vaccine and autism, and they can't find it. They just can't prove it. And then a bigger investigation was done in terms of Dr. Wakefield's studies, and the Lancet actually retracted the publication. They took it out. If you go into that issue of the Lancet, you won't find it anymore. Okay, it's like it was vaporized from its content. The General Medical Council of England launched an investigation in 2004, and they found these things. Wakefield was working as a gastroenterologist at London's Royal Free Hospital at the time of the study. He did not have the ethical approval or qualifications to oversee the research, and that although his contract prohibited him from involvement in patient care, he subjected children to invasive and unjustified procedures, including spinal taps and colonoscopies with biopsies. Wakefield was found guilty of failing to disclose conflicts of interest, including receiving funding from lawyers who represented parents of autistic children, and failing to disclose that he had a patent for a single entity measles